Yes, so we are live now.
Good evening, delegates and participants. And I also welcome everyone on this platform. And this is the first episode, Learn Simply with Dr. Kawita Bapat at tea time. So this will be episode will be carry on each Tuesday. So before we start with the session, let me hand over this session to our coordinator of this session, Dr. Richa Narkede ma'am, who is associate consultant at Bapat Hospital, Indore. So, Dr. Richa Narkede, ma'am, will introduce Dr. Kavita Bapat, ma'am. So, ma'am, I hand over the session to you, ma'am.
Thank you, Nishant, and thank you, Shield. A very warm welcome to all in this webinar series of Tuesday Tea Time with Dr. Kavita Bapat, whose passion and profession is same and love towards teaching. So as learning is never-ending process, so here we are with the knowledge extravaganza, Tuesday Tea Time with Dr. Kavita Bapat, ma'am. She needs no introduction yet. She was the past Vice President Foxy 2021 and 22. She's a director of Bapat Hospital and was organizing secretary of AICOG 22. Apart from her educational CV, I'll just love to tell more about her that she is personally an adorable teacher, adorable person, avid dog lover, coolest grandmom, passionate for sari, and she is owner of Doctors and Sari group in the Facebook, as everyone knows her from that. And her basic motto, let's grow together with a lot of great ideas, fun, and laughter. So let's enjoy this knowledge extravaganza. The screen now to you, ma'am.
Thank you so much. Thank you so much. I'll just share, and this is simple thing. Basically, the learn simply. The idea is really we have to learn things very simply. It should not be like that. Ki bahut cumbersome hai and long procedure is there. And our Jyoti Karande is over there. I think she should open the video so that she will be one of the persons with co-anchor with Dr. Richa Narkede. Today we are going to talk about the antiphospholipid antibody syndrome. See, I have already, there are algorithms and Learn Simply series over there, and I always post about it. So I just thought that we have a group discussion, interactive session, and we can teach and we can learn from each other on this subject. So today is antiphospholipid antibody syndrome. Antiphospholipid syndrome is basically most important treatable cause of miscarriage. If there is a patient with a miscarriage, and if this antiphospholipid syndrome is positive, is the one of the thing that's the most important treatable cause. And it refers to the association between, number one, antiphospholipid antibodies, that is a lupus anticoagulant. Number two, anticardiolipin antibodies. Number three, anti-B2 glycoprotein I antibodies, and adverse pregnancy outcome or the vascular thrombosis. So antiphospholipid syndrome always refers with all those things: antiphospholipid antibodies, anticardiolipin antibodies, and anti-beta 2 glycoprotein I antibodies. Now, the antibody syndrome is an autoimmune disease and characterized by the presence of maternal circulation of one or more antibodies against the membrane phospholipid, as well as one or more specific clinical syndromes. So it's very simple to find it out the way it is. Now, it is an acquired rather than inherited condition. So that's the reason we are able to treat it, such as it cannot explain the family history of the VTE, number 1, 2, and a significant family history of VTE should be a prompt testing to exclude if can be the inherited thrombophilias, included factor V or the 5 leaden mutation or prothrombin gene mutation and protein S, protein CA, and antithrombin deficiency. So make it a point very clear. It's an acquired condition, not inherited, but it cannot explain the family history of venous thrombosis, VTE. And if there is a VTE, we should know all about this. Now, how we diagnose the patient of APLAS? It required 2 distinct elements. Number 1, in the correct clinical setting and a conformity serologic testing. So approximately 2 to 4% of the healthy women will have a circulating antiphospholipid antibodies in the absence of any clinical symptoms. So it's another important point. And a routine screening for this antibodies in all pregnant women is strongly discouraged. So we should not do any testing to the normal pregnant females. Now, how we say about the diagnosis of APLAS? Number one is the clinical manifestation include. Number one is the recurrent pregnancy loss, which is defined as more than 3 unexplained first trimester pregnancy losses or more than 1 unexplained second trimester pregnancy loss. Number 2, unexplained thrombosis. It can be venous, arterial, cerebrovascular accident, or myocardial infarction. And another clinical manifestation is autoimmune thrombocytopenia, where the platelet count is not more than 1 lakh. So if all these things are there, we should be worried about if this patient is having antiphospholipid syndrome. Then recent consensus opinion suggests that the clinical conditions, number 1, such as unexplained intrauterine growth restriction, we should go and see for the APLA. If there is a massive placental abruption without anything, then also we should be worried about. And recurrent early onset of severe eclampsia be included. If the pregnancy patient is having sudden rise of blood pressure at the 16 weeks, 14 weeks, or 18 weeks or any time early, so we should be worried about APLA in those patients. So these are the clinical manifestation we are worried about. And then at least one of the 3 serological tests confirming the presence of circulating antiphospholipid antibodies is required to make the diagnosis of ALPA. We cannot blame, or we cannot say that this patient is having antiphospholipid APLAS syndrome until and unless we are confirming in 3 serological tests. I'm telling you, it's very important. Moreover, the diagnosis requires the persistence of such antibodies as confirmed by 2 or more positive tests at least 20 weeks apart. So this is another important point. Now the lupus anticoagulant, we should are worried an unidentified antiphospholipid antibodies that causes prolongation of phospholipid dependent coagulation. Now we need few tests in a vitro and vivo also. The test in a vitro is a binding of the prothrombin activator complex, and what's very, very important, and examples of the tests that can confirm the presence of lupus anticoagulant include, number 1, activated PTT test, dilute Russell Viper venom test, kaolin clotting time, and recalcification time. However, LAC in a vivo thrombosis is there, causes thrombosis, and results are reported at present or absent. No titers are given. The term LAC is a misnomer and it is not specific to the lupus, that is SLE, and it acts in a vivo as a precoagulant and not as a procoagulant and not as an anticoagulant. So make it a point with the difference between the two and you will find out. Now, when we suspect about the antiphospholipid syndrome, number 1, how to confirm the diagnosis? There are 2 things we have to do. First, what is the correct clinical setting and what are the confirmatory serological tests? In a correct clinical testing, a correct history of recurrent pregnancy loss, unexplained venous or arterial thrombosis, autoimmune thrombocytopenia, if there is unexplained IUGR or placental abrasion, or recurrent severe preeclampsia. If anything is no, the diagnosis of APLA is not be confirmed, consider the alternative diagnosis. So APLA is out if all the things are not there in a clinical setting. But in a clinical setting, any out of anything is yes. And confirmatory serological diagnosis will do 3 things: angiocardiolipin antibody, lupus anticoagulant, and anti-beta 2 glycoprotein I antibodies. If the serological test comes yes, then the diagnosis of APLAS are confirmed. In all 3 tests, if it is no, the diagnosis of APLAS cannot be confirmed. Consider for the alternative diagnosis. Now, if the diagnosis of APLA is confirmed, then how to treat it? It depends upon the clinical features. Recurrent pregnancy loss, anticoagulant therapy during the pregnancy, no postpartum or lifelong. If there is an autoimmune thrombocytopenia, recommendation unclear, consider anticoagulation pregnancy therapy in pregnancy. If there is unexplained venous or arterial thrombosis, anticoagulation therapy during pregnancy, and 6 weeks postpartum, consider the lifelong therapy. So it's very, very clear. Now, how to treat the patient with APLAS? Again, depending upon the clinical features, if there is a thrombosis such as stroke, pulmonary embolism, therapeutic anticoagulation is indicated with either unfractionized heparin or low molecular weight heparin. During pregnancy, followed by oral anticoagulation if needed, and postpartum because of 5 to 10% of the risk of this thing. So thrombosis hai, so all those things are there. Then in pregnancy, regular blood tests are required 4 hours after the administration of drug to ensure the anticoagulation is therapeutic. The PTT should be 1.5 to 2.4 normal, and anti-10A activity level should be 0.6 to 1 unit. What are the side effects if we have done the treatment and the side effects can cause hemorrhage, thrombocytopenia and osteopenia and fractures? Such women may need lifelong treatment. For women with a recurrent pregnancy loss, treatment should include the prophylactic, unfractionized heparin, 5,000 to 10,000 units, BD, or low molecular weight heparin and enoxaparin, 30 to 40 milligram subcutaneously daily. Then the dalteparin or the fragmarin is 2,500 to 5,000 units subcutaneous starting in the first trimester of pregnancy. Although the prophylactic dosing does not change the PTT, it will increase the anti-X activity to 0.1 to 0.2 unit per this thing. However, it is not necessary to follow serial anti-X activity. We don't do in our country also, and if it's not needed in such patient, but the goal of the treatment is, number 1 is to prevent pregnancy loss, to prevent VT, which is possible in women with APLA in pregnancy, even they have or had the VT in the past, and therefore anticoagulation should be administered throughout the pregnancy, typically for 6 to 12 weeks after the delivery. For women with autoimmune thrombocytopenia or a history of severe preeclampsia, IUGR or placental abruption, the optimal treatment is unknown, and it should be considered treating as far as the recurrent pregnancy loss. Postpartum anticoagulation is probably not necessary. So it's another important point. And these are the few points, and just I am adding few things before we can discuss or finding out the thing. Now the secret of happiness is very, very important. We are going to discuss few things, and that's all. I don't want that this program should be long. It's just a tea time. We should make it in a half an hour rather, but we have to put it for 1 hour. So small, simple things, not spending much time on it, and we can discuss many more things. Thank you so much. I am stop sharing over here, and we can have some discussion if anybody in the chat box. I'll invite Dr. Jyoti Karande also with me. If she can open her video, and that's all. We don't want anybody, any question we can talk about. And otherwise, that's all. Richa, anything which you talk about?
No, ma'am. We don't have any questions right now, but it was a really lovely topic, and thank you so much for making such a confusing topic in a very easily understood way. So along with the algorithm, that was too interesting. So as we don't have any questions right now in the chat box, but people are requesting for the PDF file. So definitely we will share the PDF file with them. If anyone is having any questions, they can interact with us.
They can put in a chat box probably.
Please put in a chat.
Saidi, are they allowed to open the video or unmute them?
Yes, they are allowed to start the video. Yes, ma'am.
They are allowed to.
Because it's a very not much more number. and we are going to finish it as early as possible. Next time, I don't want more than half an hour. Several other things to do. I'm finding Poonam Goyal also there.
Doctors, if you have any question regarding this topic, please share your questions with Dr.
It's a
Kawita.
chat box. There are
You
so
can
many things
also
are there.
use the
Anything
chat
which
box.
you can read it out.
No, ma'am, there are no questions out there.
Okay. No problem. It's because it's a small topic, and we will finish all this topic in a similar manner in the future also. So every Tuesday, 4 p.m., a small
Yes.
topic, and that's all. This सबसे smallest webinar.
Yes, ma'am.
Unnecessary spending time and unnecessary talking about many
But
words.
knowledgeable.
And thank you so much.
Thank
I
you
think
so
who have
much,
joined.
madam.
Huh?
Thank you so much, ma'am. It was very short and crisp.
I know we don't want to waste our time and others' time.
Yeah.
So thank you so much. That's
Thank
all. Thank you. Thank you, Sheel, for
Thank you, Dr.
supporting it.
Kavita,
We'll
ma'am,
promote
and
it.
thank
From
you.
next time we'll promote it, but this program will be only half an hour. जितना चाय पीने में जितना समय होता है उतना ही चाहिए हमको. ठीक है?
Sure. Okay.
Thank you so much. Thank you, Richa.
Thank you, Kavita ma'am, for this lovely discussion. And thank you, Sheel, for providing us the platform. And thank you, delegates, for joining us. Please stay tuned with us and enjoy this webinar series. Thank you so
And
much,
it will
everyone.
be very small and short every time. So you can
Yes.
have time and forward the link wherever you need it.